Clinical Management of Bispecific Antibody Therapy for Lymphoma, a British Society for Haematology Good Practice paper. Introduction. Bispecific antibody activate endogenous immune cells by co-targeting tumor antigens and T or natural killer cells in an Fc receptor and major histocompatibility complex-independent manner. Anti-CD3 x CD20 bispecific antibody have demonstrated remarkable activity in patients with heavily pretreated B-cell lymphomas. Epcoritamab, glofitamab, mosunetuzumab and odronextamab have all shown single-agent efficacy in patients with relapsed or refractory B-cell lymphomas, including large B-cell lymphoma, follicular lymphoma and mantle cell lymphoma. Current European Medicines Agency-approved bispecific antibody for lymphoma and the indications include epcoritamab, glofitamab and odronextamab for diffuse large B-cell lymphoma, DLBCL, and epcoritamab, mosunetuzumab and odronextamab for follicular lymphoma, in patients with relapsed or refractory disease after 2 or more prior lines of therapy. Epcoritamab and glofitamab are also approved for relapsed or refractory DLBCL in 3rd or later lines by the MHRA and recommended for use in the NHS by National Institute for Health and Care Excellence, NICE, and the Scottish Medicines Consortium, SMC, in the United Kingdom. In common with chimeric antigen receptor, CAR, T-cell therapy, bispecific antibody treatment has a characteristic and predictable toxicity profile mediated by immune activation and subsequently by B-cell depletion. However, the incidence and severity of cytokine release syndrome, CRS, and immune effector cell-associated neurotoxicity syndrome, ICANS, like neurotoxicity are much lower with bispecific antibody therapy. CRS usually occurs within 1 to 2 days of a bispecific antibody dose and lasts for 1 to 3 days, with 98% of events resolving. It is typically seen during step-up dosing, SUD, in cycle 1, most commonly after the first dose of glofitamab, C1D8, and after the first full dose of epcoritamab, C1D15. CRS is sometimes seen in cycle 2 but is uncommon beyond that. In common with chimeric antigen receptor, CAR, T-cell therapy, bispecific antibody treatment has a characteristic and predictable toxicity profile mediated by immune activation and subsequently by B-cell depletion. However, the incidence and severity of cytokine release syndrome, CRS, and immune effector cell-associated neurotoxicity syndrome, ICANS, like neurotoxicity are much lower with bispecific antibody therapy. Timing of CRS onset is also more predictable with bispecific antibody. ICANS and ICANS-like symptoms are much less common with bispecific antibody than with the currently available CAR T-cell products. The frequency of any grade ICANS ranged between 0% and 8% in the pivotal trials, with most events being grade 1 and self-limiting. With glofitamab, any grade ICANS-like neurological events were reported in 8% with grade greater than or equal to 3 events in 3%. With epcoritamab, any grade ICANS was reported in 6%, grade 1 in 4.2%, grade 2 in 1.2% and grade greater than or equal to 3 in less than 1%. ICANS resolved in 94% with supportive care. The median time to resolution of ICANS was 2 to 3 days. Strategies to mitigate against these toxicities such as step-up dose and corticosteroid premedication are routinely incorporated into bispecific antibody administration protocols. Importantly, another notable toxicity of anti-CD3 x CD20 bispecific antibody therapy is B-cell aplasia and increased risk of infections. Patient assessment and work UP. Patients being considered for bispecific antibody therapy should have an assessment of performance status and baseline blood tests to include full blood count, routine chemistry, serum lactate dehydrogenase, C-reactive protein, CRP, and serum immunoglobulin, IG, levels. A blood film and flow cytometry should be performed where circulating neoplastic cells are suspected. Full serology for hepatitis B, including core antibody, hepatitis C, and human immunodeficiency virus is also mandatory unless performed within the preceding 12 months. Formal investigation to assess cardiac function is not routinely required but should be considered in patients with known or suspected cardiac morbidity and in older patients with previous anthracycline exposure where compromised cardiac function confers additional risks in the context of CRS. A referral to cardiology or a cardio-oncology service should be made for patients with impaired cardiac function. A positron emission tomography, computed tomography, PET-CT, scan prior to starting treatment is recommended as it provides an indication of tumor burden and a baseline for subsequent response assessment. High tumor burden is predictive for increased risk of CRS and inferior outcomes. Biopsy of representative tissue for histological confirmation of disease is recommended unless it poses an unacceptable risk. While assessing CD20 expression by immunohistochemistry prior to initiating BSAB therapy is not essential and clinical trials did not routinely require demonstration of the target antigen for patient enrollment, emerging data suggest that CD20 expression does correlate with clinical response and weak or no immunohistochemical expression can be associated with suboptimal response and development of resistance. Therefore, caution should be exercised when considering an anti-CD3 x CD20 BSAB in the absence of histological CD20 expression. Practical considerations for delivering bispecific antibody. Healthcare professionals training. An important aspect of developing new therapeutic pathways is education and awareness for all healthcare professionals, HCPs, participating in the care of patients receiving bispecific antibody therapy, including those involved in acute admission pathways of the treatment facility where a patient might present with bispecific antibody toxicity. Tocilizumab, a monoclonal antibody that blocks the interleukin-6 receptor, is commonly used for the treatment of CRS. A minimum stock of 2 doses, 4 by 400 mg vials, should be routinely and readily available on the hematology ward emergency medication cupboard. Staff must be aware of the location of tocilizumab within their hospital and have rapid access to it at all times. Bispecific antibody administration. Epcoritamab is a subcutaneous injection, whereas glofitamab, mosunetuzumab and odronextamab are given by intravenous, infusion. It is recommended that systemic anticancer treatment, SACT, prescriptions are done in advance to ensure enough stock and trained pharmacy staff are available to prepare the bispecific antibody given the short 24 to 72H expiry once reconstituted and complex aseptic preparation for certain bispecific antibody, e.g. serial dilution for epcoritamab. CRS and ICANS mitigation. Strategies to mitigate against CRS and ICANS such as step-up dose and steroid premedication are routinely incorporated into bispecific antibody administration protocols as reflected in the respective SMPC. Additionally, bispecific antibody-specific strategies such as subcutaneous administration for epcoritamab and obinutuzumab pretreatment to deplete circulating B cells prior to glofitamab are designed to reduce the risk of CRS. Corticosteroid prophylaxis is essential during step-up dose, and dexamethasone appears more effective at reducing the incidence and severity of CRS compared to other corticosteroids. Steroid premedication may need to be continued in subsequent cycles depending on individual product guidance and if prior CRS has occurred. Hydrating patients prior to dosing has also been reported as a potential CRS mitigating strategy with epcoritamab. An elective admission for a minimum of 24H following bispecific antibody administration is currently mandated for CRS monitoring during SUD in cycle 1, C1D8 for glofitamab and C1D15 for epcoritamab. For odronextamab, patients were admitted for inpatient monitoring for at least 24H after each infusion during step-up dose, that is, C1D1, C1D2, C1D8, C1D9, C1D15, C1D16 and C2D1. Where patients are hospitalized for monitoring, it is recommended that observations are checked at regular intervals, of at least 4 hours. In the absence of CRS, patients can usually be discharged 24 hours post-dose. Given that neurotoxicity is infrequent, there is no requirement to perform routine ICE and ICANS evaluations unless there is clinical concern or CRS grade 2, when ICE scores should be done at regular intervals of 4 hours. Given that there is significant steroid exposure during the step-up dose phase, it is important to pay attention to blood glucose control and its management in diabetic or pre-diabetic patients. Patient and carer education and home monitoring. Patients and carers should be given appropriate information on CRS and ICANS, Symptoms to look out for and advice on self-monitoring. It is recommended that patients are instructed to monitor their temperature at home 3 times per day for 48 hours after each step-up dose until 1 full dose is administered without CRS. High-risk patients are those with a high tumor burden, impaired organ function, e.g. impaired renal or cardiac function, older patients, e.g. age greater than 75 years, and those with limited social support. For patients with multiple risk factors, consider in-person clinic review with an HCP at 24 and 48H after each step-up dose or even hospitalization for up to 48H post-dose. In contrast to CAR T-cell therapy, there is no mandatory requirement for a carer to live with the patient following bispecific antibody therapy. Recognizing and managing bispecific antibody-related toxicity. CRS grading and management. CRS is the most frequent acute toxicity mediated by T-cell activation with anti-CD3 times CD20 bispecific antibody therapy. It occurs most frequently during cycle 1 step-up dose, is usually low-grade and has a predictable onset in relation to treatment administration. The most common manifestations of CRS are fever of greater than 38 degrees Celsius, tachycardia, hypertension, chills and hypoxia. Grading of both CRS and ICANS is performed as per the American Society for Transplantation and Cellular Therapy, ASTCT, consensus criteria, originally developed for CAR T-cell therapy. Grade 1 CRS is typically managed with symptomatic measures. Grade 1 CRS persisting for greater than 24 hours should be treated with tocilizumab or dexamethasone. Tocilizumab is recommended for patients developing CRS while taking steroid prophylaxis. Earlier use of tocilizumab is recommended for patients with high tumor burden, as they are at an increased risk of higher-grade CRS, and for those with reduced physiological reserve, for example, impaired cardiac or renal function. Initiate broad-spectrum 4 antibiotics, especially for neutropenic patients and/or for CRS grade greater than or equal to 2. Tocilizumab is recommended for CRS grade greater than or equal to 2. It is important to note that fever and CRP are unreliable markers of CRS and infection once patients are treated with anticytokine therapy such as tocilizumab. CRS grades 3 to 4 are very uncommon with bispecific antibody therapy and require admission to a critical care unit. For any grade CRS, treatment with bispecific antibody should be withheld until CRS is completely resolved for at least 72 hours. If there is a delay to the next dose, repriming may be required. For patients experiencing CRS grade greater than or equal to 2, elective admission for monitoring and continuation of steroid prophylaxis are recommended for the next dose. Management of bispecific antibody-related cytokine release syndrome, CRS, in hospital. As elective hospital admission is currently mandated with most bispecific antibody therapy at defined time points during step-up dose periods posing the highest risk for CRS, many CRS episodes happen and are consequently managed in the inpatient setting. The usual recommended protocol for such situations is for patients to attend hospital for immediate assessment. Given the predictable and often low-grade nature of CRS, some institutions are exploring remote management pathways for carefully selected patients to reduce emergency admissions. Neurological toxicity and ICANS, grading and management. Neurological toxicity seen with bispecific antibody therapy most commonly manifests as headache and dizziness. ICANS-like neurotoxicity with word-finding difficulty, dysgraphia, or acute confusional state is almost always low-grade. More severe neurotoxicity is rare. The risk of ICANS is highest in cycle 1, but delayed onset may sometimes be seen. If ICANS is suspected, a thorough neurological examination should be performed, including an ICE assessment. ICANS grade 1 can be treated with oral dexamethasone. ICANS grade 2 needs treatment with dexamethasone 4 and a prophylactic anti-epileptic such as levetiracetam. Other causes of neurotoxicity must be excluded, for example, infection, opioid toxicity, medications and metabolic causes. Grades 3 and 4 are rare, should be managed in the ICU setting, and alternative etiologies should also be considered. Dexamethasone 4 and anakinra should be used to manage grades 3 and 4 ICANS, but some patients may require high-dose methylprednisolone and ciltuximab. Infusion-related reactions. Infusion-related reaction manifestations may be clinically identical to CRS but usually occur earlier. If IRR-CRS occur during bispecific antibody infusion, the infusion should be interrupted and symptoms treated. Once the symptoms have resolved, the infusion may be restarted either at the same or slower rate depending on the bispecific antibody, but permanent discontinuation may be required in the case of grade 4 IRR. If CRS is suspected, stop the infusion and follow CRS management protocol. Tumor flare reaction and tumor lysis syndrome. Tumor flare reaction, TFR, is a recognized event with bispecific antibody. It manifests as a transient increase in the size of the tumor, sometimes accompanied by pain or fever, and may cause compression symptoms if a large tumor is adjacent to a vital structure such as large airways or the superior vena cava. Breathlessness due to new or worsening pleural effusions is also reported. Most TFR events occur during cycle 1 with none reported beyond cycle 2. Therefore, the possibility of TFR may need to be considered in some cases when interpreting PET scans during the first 2 cycles of bispecific antibody therapy. Analgesics and corticosteroids can be given to patients with tumor flare reaction. Bispecific antibody treatment does not confer an excess risk of tumor lysis syndrome, TLS, beyond that seen with conventional large B-cell lymphoma therapies. Most TLS events occur during cycle 1, with time to onset from treatment initiation varying between bispecific antibody, median of 2 days with glofitamab, 18 days with epcoritamab, and on days 2 and 24 with mosunetuzumab. Cytopenias and infections. The incidence of grade greater than or equal to 3 neutropenia was reported to range between 19% and 29% and usually responds to granulocyte colony stimulation factor, GCSF, support. GCSF is recommended for all patients with grade 4 neutropenia, 0.5 times 109L, and should be considered for grade 3 neutropenia, 1.0 times 109L, especially if it is persistent or worsening. The incidence of febrile neutropenia was 2.1% with glofitamab and 2.4% with epcoritamab. Treatment discontinuation due to neutropenia is uncommon but should be considered if grade greater than or equal to 3 neutropenia associated with infections occurs and does not respond to GCSF support. In patients remaining well despite neutropenia, it may be optimal to continue bispecific antibody therapy and monitor closely. Infections, not necessarily associated with neutropenia, were reported in 38% to 59% of patients with grade greater than or equal to 3 infections in 15% to 33%. Commonly reported severe infections were COVID-19, 32%, clinically diagnosed pneumonia, 26%, and sepsis, 12%. Severe opportunistic infections reported infrequently include reactivation of herpes simplex virus varicella zoster, cytomegalovirus and Epstein-Barr virus, as well as severe influenza, toxoplasmosis, pneumocystis jirovecii pneumonia, PJP, and fungal pneumonia. Bispecific antibody treatment should be withheld in the presence of active infection. In patients with asymptomatic COVID-19, it may be appropriate to continue bispecific antibody treatment after assessing risk versus benefit on a case-by-case basis. Varicella zoster virus, VZV, and PJP prophylaxis are recommended throughout bispecific antibody treatment and should be continued until the CD4 count has recovered to 0.2 times 109L. Antifungal prophylaxis is not routinely required. Live vaccines should be avoided. However, it is recommended patients have all routine non-live vaccinations, including those for COVID-19, influenza and varicella zoster, where available. Hypogammaglobulin and B-cell aplasia. Anti-CD3 times CD20 bispecific antibody causes profound and prolonged B-cell aplasia and hypogammaglobulin. On continuous therapy with epcoritamab, serum IgG levels dropped by a median of around 20% and remained stable over time. With fixed-duration glofitamab therapy, recovery of B-cell aplasia and IgG levels was observed starting from around 18 months after the end of treatment. A persistent IgG level of 4 GL is associated with a higher risk of infection. Consider immunoglobulin replacement therapy, IGRT, in patients with recurrent or severe infections despite antimicrobial prophylaxis with IgG levels of 4gl. There remains concern that patients initiating bispecific antibody therapy for progressive disease, PD, following CAR T-cell therapy may develop more severe B-cell aplasia and hypogammaglobulin, although further data on this are needed from studies in the real-world setting. For those in a sustained CR, it may be reasonable to consider stopping treatment where the benefits of continuing are outweighed by cumulative toxicity. Response evaluation. Response assessment scans were performed at 6 and 12 weeks from treatment initiation. In routine clinical practice, a pragmatic approach would be to perform a PET-CT scan after cycle 3 unless there is clinical concern for disease progression, recognizing that many patients will not respond. It is important not to prematurely conclude stable disease or PD response on PET scans, especially if performed early after initiating bispecific antibody therapy. TFR is reported with bispecific antibody therapy, is usually early in onset and should be differentiated from true progression. If a patient remains clinically well, it is generally preferred to continue treatment and rescan or biopsy before discontinuing treatment. For patients in a complete metabolic remission, CMR, after 3 cycles, a repeat PET scan after cycle 12 can be considered to document ongoing response status. For those not in a CMR after 3 cycles, a further PET-CT scan after another 3 cycles and thereafter as clinically indicated is recommended. Recommendations. Baseline evaluation of patient suitability for bispecific antibody therapy must include assessment of performance status and organ function. 1A. Perform baseline PET-CT scan to assess tumor burden prior to initiating bispecific antibody therapy. 1B. Biopsy of representative tissue to confirm histology is recommended unless clinically unsafe. 1B. Healthcare professionals involved in emergency admission pathway for patients on bispecific antibody treatment should know whom to contact for advice, and this advice needs to be accessible at all times. 1C. A minimum stock of 2 doses, 4 by 400 mg vials, of tocilizumab should be available in the hematology ward emergency medication cupboard. 1B. CRS should be graded as per ASTCT criteria and managed according to the severity grade. 1B. Administer tocilizumab early in grade 1 CRS for patients with high tumor burden and/or reduced physiological reserve. 1B. Perform infection screen for all patients with suspected CRS. 1B. Initiate broad-spectrum 4 antibiotics for neutropenic patients with any grade CRS and/or for patients with CRS grade greater than or equal to 2. 1B. ICANS should be graded as per ASTCT criteria and managed according to the severity grade. 1B. Bispecific antibody treatment must be interrupted until resolution of CRS or ICANS. Depending on the duration of dose interruption, repeat step-up dose may be required. 1B. Interrupt bispecific antibody treatment in the presence of serious, active infection. 1B. Consider immunoglobulin replacement therapy in patients with recurrent severe or prolonged infections despite antimicrobial prophylaxis with IgG levels of 4gl, 2b. VZV and PJP prophylaxis is recommended throughout the duration of bispecific antibody treatment and until CD4 count recovery to 0.2 times 109L, 1b. Offer routine non-live vaccinations including COVID-19, influenza and varicella zoster, but avoid live vaccines for patients on bispecific antibody therapy. 1C. Thank you.